we are back from our break. I hope that everybody had the chance to get a cup of coffee and some food. And after these 3 very exciting introductory lectures, we are now continuing with topics that are directly related to clinical centers, to hospitals. And we are very happy to have as a first speaker, Hasibeder. Hasibeder got his training and education as a physician at the Medical University in Innsbruck. He spent 10 years as a director of anesthesia, intensive care and palliative medicine in a hospital in Ried in Innkreis in Upper Austria. And then he became medical director of the operative intensive care medicine in the St. Vinzenz Hospital in Zams. And Walter is going to speak about how to prepare an ICU for a pandemic. Walter, please.
Thank you very much. Thank you for the invitation. Our hospital lies in the western part of the county of Tyrol, which was the hotspot during the first wave of the outbreak of COVID-19. This is a short time frame of the spread of SARS coronavirus 2, not only in Austria, but also in Tyrol. On the 24th of January 2020, we had the first case.
Excuse me for a second, Walter. We cannot see you. Maybe this is on purpose, but if you switch on your camera, then we can also see you while you give this presentation.
Just a moment. So during the 24th of January 2020, we had the first case of SARS coronavirus 2 infection in a German businessman in the region of Kütai. The transmission occurred through a Chinese instructor during a business seminar in an alpine hut. On the 25th of February, we had a PCR positive couple, which was working in a hotel in the midst of Innsbruck. And they were the first patients in Innsbruck and had only mild symptoms and were isolated at the university hospital, and they recovered very rapidly. On the 27th of February, we had the first 3 infections diagnosed in Vienna. And then on the 6th of March, we had the first case detected in Ischgl in the Bad Snauntal, which is near to our hospital. 3 Erasmus students, which had visited Italy, the Lombardy, before starting their skiing holidays, were affected. At that time, only 5 cases were known and detected in Tyrol. 3 cases were in Ischgl. 1 was in Petnoi, which is in the Arlberg region, also very near to our hospital. And 1 was in Kitzbühel, it's in the other part of Tyrol. Between March the 7th and the 17th, we had 145 PCR-proven infections in the region of Ischgl. And from the 10th of March to April the 13th, there was a rapid spread of SARS coronavirus 2 infections in the region of Landeck and Imst. The incidence in Landeck was around 2,250 cases per 100,000 inhabitants, which is very high. It's higher than reported from Lombardy. And the overall incidence in Tyrol at that time was 440 cases per 100,000 inhabitants. You all know these slides very well. We had 2 waves of infection. Probably we are now in the 3rd wave. The first wave was between March and the end of April, beginning of May. And during that time, we had a no-COVID strategy, which means that we were even not allowed to leave our houses, our flats, with the exception of working, going to work, with the exception of helping persons who are in need of help, and with the exceptions of buying food and medications. And the infections very fastly decreased, and during June and July we thought everything is over. But then it started again, and during the 2nd wave we had a lot of infections also in the hospital. During the first and the second wave, until the end of January 2021, we had 458 hospitalized COVID-19 patients in our hospital. During the first wave, we had 154. During the second wave, 304 patients hospitalized. 16.2% during the first wave, and 12.5% of these hospitalized patients during the second wave were transferred to the intensive care unit because of severe respiratory failure. So if you look for the second wave, we had a minus of 3.7%. We believe that probably the early starting of a cortisone therapy, according to the WHO recommendations, was able to mitigate the disease, at least in some patients. During the first wave, we had a COVID-19 mortality of 11.7%, and during the second wave, we were on 13.5%. Now, if we talk about hospital mortality and we compare it to the usual mortality in our hospital, it's between 0.9 and 1%. And we have a hospital with a big oncological department and a very, very important surgical department and emergency department. So COVID-19 patients really had a high risk of dying in the hospital. Now, our initial considerations were at that time when the patient entered the unit and the hospital, there were few scientific reports on the infectivity of the virus and on the pathogenicity. And there were only few reports on the right personal protection and hygienic measures to protect the nurses and doctors in the hospital. So our first strategic goal was to establish a pragmatic barrier concept between the staff and the virus or the infected patients. So we looked at the barriers between rooms, the barriers between patients and staff by means of an adequate personal protective equipment. We made barriers regarding logistics and organization in the ICU. And of course, we talked a lot about general hygienic measures. And the second goal was to rapidly and sufficiently train the ICU staff to handle all these measurements and barriers. So this is a normal floor plan of the interdisciplinary ICU. We have 3 entrances. One is here, the main entrance. Usually all patients and staffs enter the ICU via this entrance. There is a small room for visitors who can wait there until they are allowed to visit their beloveds. And we have usually 5 2-bed rooms for ICU treatment. It's a so-called category 2 ICU ward, which means that everything can be done with the exception of ECMO in our ICU. The 6th room is closed. It's reserved for the newly coming neurological department for treatment of epilepsy and neurologic disorders. And we have a room 8 and 7, which is designed as an intermediate care room for 2 patients per room. In addition, we have a back entrance to the recovery area. So sometimes we transfer patients who are getting worse from the recovery area to the ICU via this entrance. And there is a side entrance which is used by staff members and sometimes by members of the logistic teams. So now I want to talk about the barriers between rooms. First, to the patient room. Fortunately, the air condition between the rooms is separated, so there is no air mixing between rooms, and each room is, concerning the freshness and the hygienic standards, separated from each other via the air condition. During the pandemic, we left all logistic equipment in the patient room, which means patient charts, the medications, they were brought into the rooms once a time during the day, the electronic equipment, pens, and everything. The recreation room and the ICU kitchen the doctors and leading nurse office in the ICU area were closed during the first wave of the pandemic. And the third barrier was everybody was forced to keep strict adherence to labeled routes. So we had a marked entrance and we have marked exit routes for staff and suppliers and even patients. And there was only a one-way patient transportation allowed. So what we did first is we closed the back entrance of the ICU. Patients, COVID positive patients, were only allowed to enter the unit via this main entrance. Here we had a personal lock. All the personnel, the staff, the doctors had to dress up the personal protective equipment here and then enter the unit. The whole ICU was designed as COVID ICU. Here, in the direction of the recovery area, there was the ejector area. So those who left the ICU, staff members, doctors, had to undress here and then left via the side entrance. But also patients who recovered from COVID-19 left the ICU through this entrance. We had, during the first pandemic wave, 14 ICU beds, so the IMCU rooms were equipped with respirators, and we had 4 places to treat COVID-19 patients. So this is how it looked in reality. Everything was marked. ICU station, you are not allowed to enter here, with the exception that you have the electronic card. Then patients go into the ICU via the side entrance and leave the ICU via this entrance. And this is the so-called clean area. Here, the personnel, the staff and the doctors had to dress up with the personal protective equipment. The personal training was fast and pragmatic. At the beginning, we made several short training sessions how to dress and undress yourself in the morning meeting. We taught how to perform the new logistics and new organization within the ICU. And afterwards, we had a hygienic member of the hygienic team at the main entrance and at the exit of the unit. And they looked how the staff dressed and undressed themselves and how they did it. And they made, they showed them if there were any mistakes. In addition, we had at the entrance and the exit photos and a short text how to do dressing and undressing. Some of the members of the hygienic team, together with the staff of the ICU, elaborated a script describing all hygienic SOPs, standard operating procedures regarding our ICU. In addition, we made training videos which were transferred into the intranet, so everybody could look at the training videos and inform himself how to do the right way, how to do it the right way. In addition, we made every week information videos on material, on hospital patient occupancy, and on the material stock in the hospital. So everybody got every information about the pandemic and the situation in the hospital. So this is how the internet looks like, even now. We have actual information on COVID-19. We have actual videos. We have standard operating procedures, how to deal with palliative patients during that time. We even give the staff and the hospital members information about the newest COVID-19 literature. We always have the latest information on COVID-19 numbers of patients in the hospital and our hygienic standards. Organizational things, we said the same teams should always be with the same patients. So there was no team mixing between patient rooms, with the exception if we did prone positioning, then you need more personnel. Sometimes personnel from another room got into that room where the patients were turned from supine to prone position. So there's no team mixing strategy guaranteed the continuity of care and medical treatment. We allowed our staff members to get into regular breaks 2 to 3 times per 12-hour shift, because they had an extremely high workload during this time in a very stressful protective equipment. We shifted personnel from the anesthesia department because there were much less elective surgery, and from the recovery area into the ICU to help and to do intensive care nursing. Usually we only have 2 intensivists during the day shift, 1 internist, internal medicine specialist, and 1 anesthesiologist. During the first wave, we had 4 intensivists and 2 intensivists during the night. And of course, we had an increased availability of physiotherapists in the ICU. Usually we only have 1 during the day, but at that time we have 2 to 3 physiotherapists for helping those patients who are getting better, getting out of the bed and doing exercises with them. And at the beginning, we had some problems with high quality masks. And so we did a lot of recycling of personal protective equipment, stream sterilization of FFP2 and FFP3 masks. And afterwards, these masks were hanging on such rods. And what you see here is that 2 persons did it the wrong way. They covered this mask with plastic. Of course, the hygienic team immediately reminded them that the mask should be left open and should have the chance to dry. Otherwise, they will fail. We had a lot of problems with this type of protective clothing because these waterproof plastic suits, they cause heat stress, they cause fluid losses by sweating. And in addition, of course, they are disposable products and they end as a special mill after single use. And we changed this during the time. We switched to cotton gowns and used plastic aprons for every patient contact. In addition, we wore, of course, 2 pairs of handschuhe. And in addition, we had these goggles on our heads. So during the second lockdown, during the second wave, we have learned a lot. And what we knew at that time was that the infectivity of the SARS coronavirus 2 is low as long as hygienic standards are strictly observed. We had no single infection in the ICU of a staff member or a doctor. In addition, we learned that an infection via contaminated surfaces seems to be a very rare event. So it's mainly an infection through droplets and aerosols. We have learned that personal protective equipment using cotton coats and plastic aprons, FFP3 or 2 masks, eye protection and 2 pairs of gloves gives a very effective and sufficient protection against the virus. Outside the intensive care unit in the operating room and recovery area, we used mainly FFP2 masks, and this was sufficiently safe. During the second wave of the pandemic, we ran the ICU as a flexible hybrid ward. And in case of an overload of the ICU, we moved with ICU patients, non-COVID patients, to the recovery area and did ICU there, intensive care medicine there. So during the second wave, we had 16 approved ICU beds of category 6, of category 2. We had personnel from the anesthesia and recovery area to cover these 2 additional beds. The back entrance was still closed during the second wave. Non-COVID patients, staff members, entered the ICU via the main entrance. COVID patients entered the ICU via the side entrance. And these were the COVID patient rooms. We started always at the room nearest to the back entrance and filled up the ICU beds with COVID-19 patients and moved this flexible screen, which is the border between non-COVID and COVID area in the direction of the main entrance. This is how it looks like in reality. This is the flexible screen. Here is the COVID-19 area, and here was the non-COVID-19 area. We moved with non-COVID patients for intensive care unit, for intensive care medicine, also in the recovery area. So 2 rooms in the recovery area were designed for ICU treatment of non-COVID patients in case we had all beds in the ICU occupied. Once more, we had the same teams with the same patients. There was no team mixing between non-COVID area and COVID area. Only the intensivist on duty, and this time we only had 1 during the day, switched between the areas after changing the personal protective equipment. The personal protective equipment in the COVID-19 area was, as already mentioned, cotton coats, plastic aprons, FFP3 masks, eye protection, and 2 pairs of gloves. In the non-COVID area, we used only FFP2 masks. We had 2 intensivists, not 4, sondern 2 during the day shift and 2 during the night. And we had also an increased availability of physiotherapists in the ICU during the second wave. I just want to share some data with you from the first and the second wave. There was a change in patient demography and comorbidities between the first and the second wave. Patients become 10 years older during the second wave. We saw more patients with arterial hypertension in the second wave and more patients with diabetes mellitus. Overweight adipositas is not a problem in our region. There is no difference in ICU data between first and second wave. The SAPS-3 score is a marker of physiologic derangement in the first 24 hours after admission, and the SOFA is the maximum SOFA sequential organ failure score of patients in the unit. But what you see here is interesting. The mortality increased from 12.5% during the first wave to 36% during the second wave, and this is highly statistically significant. Another thing which has changed is during the second wave, we saw a lot of people which developed within a short time significant pulmonary fibrosis. We have no idea why this happened to them. It's not just age or more pre-morbidity, because on the other hand, we had less renal failure necessitating veno-venous hemofiltration, so renal replacement therapy. And we also had less cardiovascular failure during the second wave. So we had the impression something has changed with the lung pathogenicity of the virus. However, during that time, no sequencing of virus was made. And with this slide, I want to thank you for the opportunity to give you this talk. Thank you very much.
Thank you very, very much, and bravo on behalf of all of us. That was extremely interesting because it took us from this global view that the EPID gave us down to the nitty-gritty daily operational work in a ICU, how to organize the people flow, how to organize the patient flow, how to organize the material flow, and how to really prevent risks. I've got 2 questions here in the chat that I would like to ask you on behalf of first question is, will any of the fantastic COVID-19 hygiene activities also be the question is, will any of these COVID-19 activities also be implemented or continue to be implemented if the pandemic is over?
Yes, of course. What we will still have implemented is there is more hand hygienic measurement, or more hand hygiene, or an improvement of hand hygiene during the pandemic. This is what I really saw. I think there was no other time, as long as I am a clinician and working in the field of intensive care medicine, where hand washing was so important and was performed by really all members which are working in the ICU then during this pandemic. And I hope that this, and I'm pretty sure that this will last even if the pandemic is over. However, we will not use the personal protective equipment, and we will change to usual masks, to normal surgical masks afterwards.
Okay, I see. And there is a second question that is, no, a third one already, but then we have to stop because Elke is already waiting. If you use 2 pairs of gloves, did you change only the top pair or both when changing to another patient?
We changed only the top pair.
Only the top pair. And from Ariana, thank you for sharing your experience. What is the reason for wearing 2 pairs of gloves?
It's hard to answer that, but sometimes we have small lesions in these very cheap gloves we use in the intensive care. So we thought it's better to protect ourselves with 2 pairs so that it's really tight and there is no contamination of the hands by touching patients or any type of furniture in the room.
Thank you very much. I think these 3 questions are answered.